Welcome, everyone, to today's webinar produced by the EMS for Children Innovation and Improvement Center, Pediatric Suicide, How EDs Can Change the Paradigm. We're going to be talking about our new collaborative emergency department screening and treatment options for pediatric suicide quality improvement collaborative. Next. Of course, we'd like to thank our HRSA colleagues. We are so very grateful for your support. Next. Today, we're going to talk about a variety of issues. As you can see on the screen, I'm pretty sure that every one of us has been touched by someone we know having suicidality or a mental health condition. It's a really important topic. And we're going to take a look at what we can all do collaboratively to improve the efficiency of the clinical care processes within emergency departments across America. Please feel free to add your questions into the Q&A box, not the chat box, the Q&A box, and then our panelists will answer those questions during the presentation as they can. And if we have time at the end, we will talk to the panelists and answer any final questions. If there is a question that we do not get addressed, we will email you after. And yes, this webinar is being recorded, and the slides and the recording will be posted on the webpage within a few days, and all of you will receive an email with that information and those materials too. Next. We have a very distinguished panel of speakers. Chip Schreiber, Dr. Susan Duffy, Dr. Mo Saidinejad, sorry Mo, Dr. Kate Remick. Next. I'm going to turn it over to Dr. Schreiber to tell you a little bit about himself and to proceed. Thank you very much.
Greetings, everyone. I'm very happy to be part of this historic effort for our country and our nation's children. I'm Chip Schreiber. I'm a clinical child psychologist on faculty in pediatrics at the Lundquist Institute at Harbor UCLA Medical Center and faculty at the David Geffen School of Medicine at UCLA. I work also in a number of disaster and terrorism initiatives. I'm part of the National Center for Child Traumatic Stress at the UCLA Duke Center. And I facilitate mental health aspects for pediatric disaster response for the Western Regional Alliance for Pediatric Emergency Medicine and the Pediatric Pandemic Network. I'm one of the mental health co-leads. Next, please. So the mental health issues that we're talking about right now, certainly they've been on the rise before, during, and after COVID, but at the moment, and in the recent last few months, it's really been mental health surge on top of the unprecedented pediatric surge, which I'm sure all of you know. And suicide, before COVID and the additional impacts it's had, is the second leading cause of death of adolescents in the United States. And for a long period of time, it's been creating additional surge demands and challenges in the EMSC context. There's really an urgent need to move the ball forward for pediatric mental health across the nation. And, I think the things that are going to be offered in this historic effort really represent, components of a comprehensive trauma-informed continuum of care approach. And definitely we're aware that there's significant further challenges compounded by disparities in access to care in many areas of the United States and within many communities. So that's kind of the context for some of this. Next. And, there's been efforts at the state level, at the Children's Hospital level. This is an example from Children's Hospital of Colorado, where they declared, quote, a mental health state of emergency in early 2021. And you have one of the PEMDocs at Children's Hospital Colorado kind of sharing his view, which certainly parallels my own, which is we can't depend on building beds to get us out of this. So it's not just solutions at the ED level, but certainly that is, the piece of the pie, and that's kind of where the action efforts are definitely focused. But we need to be mindful of the comprehensive approach to these challenges that we all face for our nation's kids. Next. There's really been some historic efforts. This is just a very short timeline. In 2019, HRSA actually released the critical crossroads. Many of my co-presenters and others of you across the nation and HRSA program staff were instrumental in the creation of this document, which is really looking at a comprehensive care pathway and resource toolkit. The link is actually there. You can also just Google the title. It's a fantastic document. Then COVID happened, and in 2021, you had a historic declaration from the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, the Children's Hospital Association, an emergency declaration related to this pediatric mental health emergency. It was followed up by a letter to the president that was then signed by an additional 134 other organizations, including my own, the American Psychological Association. Then in 2022, kind of middle of the year, the U.S. Preventative Services Task Force made recommendations on screening for anxiety and depression in primary care, really the first time, and some of those go down to 8, the depression one goes down to 12. So this is also historic recommendations on screening efforts, which will certainly, lead to increases in identification of cases and triggering the need for this call to action that we're all focused on. And then coming up in August of 2023 for trauma centers, the American College of Surgeons Committee on Trauma has a new requirement for mental health screening for all adult and pediatric trauma patients that are in verified trauma centers. So that's slightly different, but it's another sort of comorbidity, acute traumatic stress definitely has an overlay with the population of interest in this project. Next. And that's just the image of the Surgeon General's advisory, also historic, on protecting youth mental health, and some stuff from the AAP and that joint declaration. So if you haven't seen those, they're historic, they're really important. They outline the Surgeon General's report, reviews a lot of the key literature that's behind these efforts. Next. In my own state, there's been a significant initiative in the last 18 months toward the youth mental health program challenges. And we already know, in California at least, that mental health issues are now the leading cause of hospitalization. That's really striking. And 1 in 3 7th and 9th graders in California are reporting chronic sadness. And when you look at 11th graders, it's half. And the rate is doubled in other underserved groups. So you can just see by the logos at the bottom of that slide, within California, the Department of Public Health, the Surgeon General's Office, Healthcare Services, and the umbrella agency, Health and Human Services Agency for California, just really kind of the uniting behind these challenges we're facing. Next. This is national survey data, not hospital-based, from CDC. So this is essentially population level metrics. 1 in 3 high school students experiencing poor mental health during the pandemic, and nearly half of the students feeling persistently sad or hopeless. So this is a little different than the California data. And then the LGBTQ disproportionate, also female students. And you'll see some other similar kinds of data on the ED visits from our colleague, Dr. Duffy, coming up in a little bit. Next. That's just a graphic. This is really striking at the population level to see these metrics, and you can certainly understand why there's an impact on the ED environment across the country. Next. And this is some data from our colleague Jeff Bridge at Nationwide Children's, who presented this to the National Academy of Medicine last year. This is younger kids, so you're probably more familiar with the 12 to 17-year-old data, but this is looking at, again, pre-pandemic, 1999 to 2018, the suicide rates. This is completed suicide deaths. The number is low, but the rate of change is very, very alarming to me, at least. Next. And this is the self-harm. These are ED self-harm presentations. And you can just see the numbers obviously are much higher, and the trending is definitely concerning in very, very young kids. Next. This is survey data, kind of looking at it differently. This is not ED. This is part of the CDC's Youth Behavior Risk Survey. So there's some really important metrics out there at the population level and the ED visit level that we really need to continue to understand better and follow, and then act on, which is what ED Stop is all about. Next. We know there's disparities. I kind of highlighted that a little bit before. And we know that less than 12% of kids that have adolescents that have comorbid major depression and a substance use disorder, which is definitely, increased risk, receive treatment for both conditions in the 2011 to 2019 period, and very underserved, groups associated with that. Very extensive disparities: Hispanic adolescents with co-occurring conditions, Native Hawaiian or Pacific Islander also. And moving, that's certainly another component to this, disrupting continuity of care when care does exist. Next. The pandemic has definitely intensified things. There's multiple pathways of causality toward increasing mental health emergencies. And this is just one, but I think very salient: the level of traumatic grief and loss tied to COVID, which continues to occur. Next. And coupled with increased risk, increased difficulty in accessing care. So this is in the 2021 pandemic, interpandemic period, if you will. Next. Nationally, I'm sorry, I showed you national data. This is international data. This is sort of a systematic review looking at population level data of clinically elevated depression across the world during the pandemic period, and essentially a doubling across the world. Striking metrics, if you will. Next. And rate changes, and again, this is looking at race and ethnicity, sex, and rural, metro versus non-retro. So you can definitely see there's definitely groups, and we're definitely eager to engage those in rural areas and those that are critical access and serving these underserved populations. It's really, really important. Next. And this is just data from one of our colleagues, Jennifer Hoffman at Lurie Children's Hospital in Chicago, who did a study in the PCAR network. And of course, there's an alarming number of suicides in the study period in this 2015 to 2016 that they looked at. 2/3 of the U.S. counties in the same time period of the study had a mental health professional shortage. And through some very sophisticated methodology, Dr. Hoffman and her colleagues were able to show there was actually increased suicide risk was associated with living in one of those designated health professional shortage areas. And also tied to the shortage area was also associated with greater risk of firearm suicide, completed suicides. And those areas also suffered with other challenges, other comorbidities, social determinants of health, if you will. Next. And this is just what this health provider shortage area, mental health provider shortage area map looks like. This is HRSA data. You can definitely go onto HRSA's website and plug in your own county and really see the drill down. And it's striking what the level is across the nation. And the next slide is actually just California, just an example of how the drill down looks like when you magnify it, and how much of California is in a high needs area, and how very few areas don't show up as a shortage area for mental health providers. And when you look at children's mental health providers who are trained to work with kids, it's even a greater magnitude of disparity. Next. And thank you very much. Dr. Duffy.
Dr. Duffy, you're still muted.
All right, sorry. Technological difficulties. Thanks so much, Tip. That was really, actually, in a way, disturbing, but I think it's something that we all know. If I were to think about what's my call to fame in this area, it was really, I was probably an early adapter. Like many of you, I'm a pediatric emergency medicine doctor. I work in a children's hospital in Providence, Rhode Island, and have been in this field for 28 years. And I've spent much of my career working on systems to bring children's mental health to our emergency department. As Chip has shown, he's shown the rationale for why we're all joining this important QI collaborative. My emergency department is joining, and we have some systems in place already. So I'm really excited about this collaborative and for participation in emergency departments, big and small. Suicidal ideation and self-harm are the #1 cause of mental health ED visits in children and young adults, and have, as we know, increasing steadily in recent years. And this is no surprise to those of us who've been on the front lines of children emergency care, because we've been in the midst of this evolving crisis for years. I think if you look at the data, it's been over 10, even dating back as much as 15 years, as emergency departments have become the de facto sites for mental health crisis screening, and for many patients is the point of access to care. As Chip pointed out, there's a shortage of children's mental health resources, but there's not a shortage of crises. And like other medical crises, children seek care in emergency departments. We are the safety net for healthcare. But there's some unique challenges, as we all know, in caring for patients who are identified as suicidal because of the sometimes covert and waxing and waning nature related to suicidal ideation and intent in youth, and the challenges of identifying those at highest risk of mortality, and in addition to the lack of systems that we have in place in emergency departments. Therefore, establishing methodical emergency department processes for screening, assessment, ED management, and disposition, and having the availability of expert consultation and collaboration is really key to best practice care. The mental health crisis has really changed the focus of our emergency department, and I'll bet just about everyone can say that. Very few pediatric emergency medicine or emergency medicine physicians went into this subspecialty expecting to require a lot of psychiatric expertise, but over time we've had to develop it. And I think a long time emergency departments have rationalized this increase as transient, seasonal, not really set an emergency, and it gives a rationale for not establishing specific systems, that they weren't necessary, that they weren't really our patients. But, you know, as we all know, we don't get to choose our patients, they choose us. And these youth are in crisis. And so we have to adapt our systems and cultures in the ED. I think, let's see, what slide are you on? Just stay at that slide. I will tell you when to go. Thanks, Christina. So what is suicide care? It's in our lane in the ED. Can you go to the next slide? Yeah, thank you. And ED interventions really can impact mortality. Why is it our lane? Well, if you look at the population of children who come to emergency departments, we know that a significant proportion of patients who die by suicide have sought acute in emergency departments. We know that many of them have not been identified. We know that 2/3 of children presenting for ED care for suicidal ideation are discharged home. We know that consistent follow-up is variable, and specific referrals really depend on resources. And we know that there's increased mortality within a year of those who seek care for injury, suicidal related injury, and for increased suicidal ideation. And that the peak risk is really within months of being in the ED. So this is our lane. Emergency medicine is not the solution to the mental health crisis, but we are an important path to management and care and focus on the high quality suicide care that EDs are designed for. And that there are meaningful interventions really are in our lane. Can I see the next slide, please? Just to give you a little bit of story about our emergency department, and maybe many of you can relate to it. This is a snapshot of our EPIC track board on one given day in October. We have 50 beds in our emergency department. We see 60,000 patients a year. We see 3,000 patients a year with mental health complaints. On this given day, we had 24 out of our 50 beds were occupied by kids with mental health disorders. 14 of them were boarding. Our short stay unit had been converted into a boarding unit. We had another 8 who had waited over 8 hours for care to be evaluated. Just overwhelming. Our inpatient service was also full of children waiting for mental health beds. And this is our reality. And think about how it impacts our other patients. There were 40 patients on that particular day in our waiting room with an average wait time of 44 hours. I would have thought this was unheard of 10 years ago, but looking back, by 12 years ago, we didn't have a psychiatric consultation in our emergency department. Social work evaluated the patients. They were transferred either with their parents to go to a community mental health center or wherever their insurance happened to pay, or else they were sent by ambulance to a hospital. We had some poor outcomes because of that practice. And around the same time, the community mental health centers lost federal funding, and so we didn't really have the resources. So we just started with daytime psychiatric consultation from the community, and then we had kids waited overnight and for an evaluation in the morning. But as the volume increased and we became the point of access, especially for the most vulnerable and special needs, we slowly developed a consult service so that we now have a full-fledged emergency consult service that involves, we see over 25 children a day. And it's run by child psychiatrists, but it's mental health clinicians. We have 4 dedicated safe rooms. We do not have a separate psych ED. But we develop processes for screening and safety, consultation, outpatient crisis services that really evolved for the need. Our staff were trained in de-escalation, and boarders are admitted to a general medical unit, but over the years, really the longer they've spent more and more time as we've developed pathways and crisis response. Next slide. So it felt like at the time that we were writing the book on our own and there was no guidance. We were following a path without a map. Yet there really have been some paths preceding us. And I think that one that's important that everyone should read is Zero Suicide. This is the really first roadmap for suicide care that looked at the ED as part of the continuum of care, recognition of the importance of community collaboration and patient engagement to improve outcomes. And it's really powerful, and it was the first to really highlight evidence-based practices and establish quality indicators. And that was followed by a white paper by IHI, the Institute of Healthcare, to look at ED mental health care. But there wasn't really anything for children. Next slide. And that's where critical Crossroads came in, as Chip described. This was really a toolkit for pediatric mental health care and to help EDs provide a framework, which is a good resource for us all. Next slide, please. And then more recently, after the American Academy of Pediatrics partnered with ACAP and CHA to declare a national health emergency, they convened a youth mental health summit. And as a result, the suicide blueprint for youth suicide prevention came out. And this is really full of a lot of useful tools, referrals, and processes that can be integrated into ED care. Next slide. So from participation in this quality collaborative, it really gives us an opportunity to look at the fundamental processes that every ED should establish that are age and developmental specific, family focused, that includes screening, assessment, consultation, interventions, ED brief interventions, safety planning, lethal means restriction, follow-up, transitions. So that, because for every emergency department, there's one focus that if it all seems overwhelming that we could focus on. Next slide. And then and on top of that is to think about how can we adapt our emergency departments to care and meet the needs of youth with mental health crises. We can't all have emergency departments designed separately, but we all can make certain adaptations. It's really great to learn from others. Last slide. So as we know, everything is local. And then we have to appreciate that. And it's great to learn from the experiences from others and performing like an environmental scan of our readiness to assess how prepared we are, to look at our resources, to build our team and to evaluate our processes. That's the experience we went through. And I can tell you that we're going to focus on a topic that has to do with safety planning and discharge and lethal means restriction, to bring that into our team and make it a team discharge process and using quality processes. So I think it's a really great opportunity for all of us. Next slide. Now I'm going to turn it over to Dr. Sachinajad, who's going to tell us more about the role and impact of emergency departments.
Thank you so much, Dr. Duffy. I hope you guys can hear me okay. I am Mo Saidinejad. I am a faculty at Harbor UCLA in the Department of Emergency Medicine. I also direct the Institute for Health Services and Outcomes Research at the Lundquist Institute, which is attached to Harbor UCLA. I'm director of pediatric emergency medicine for the UCLA's main hospital, as well as part of the executive core and one of the site investigators for the EMS for Children Innovation and Improvement Center, as well as the Pediatric Pandemic Network, both of which are funded by HRSA and are an exciting part of the work that I do. Next slide, please. Yeah, just going to forward these couple of things so everything populates, please. Yeah, so I'm basically going to reiterate some of the concepts and some of the data that was already shared, and it's just important to keep re-emphasizing the importance of the problem of behavioral and mental health. And as mentioned again, 1 in 5 of all adolescents have been grappling with some sort of serious medical mental health problems, and whether those are diagnosed or not, those are some of the facts that adolescents are dealing with. And not only that, there is serious mental health going around, but there's also a large cause of morbidity and mortality. So the problem is just the scope and also lethality. We also are running into this problem of an increasing in the prevalence of the problem. So it's escalating year by year. And finally, the problem is not equitable. We know that there are groups of adolescents and children who are particularly at high risk for having mental and behavioral health issues, as well as the seriousness and the severity of the mental health problems that they deal with. Next slide, please. So this basically shows you the green boxes are where suicide lives. And as you can see, for the 10 to 12 to 14-year-olds and the 25 to 34-year-olds, suicide is the second leading cause of death, as well as for the 15 to 24 and then 35 to 44, which is number 3 and number 4. So it really accounts for a huge proportion of our public health problem. Next slide. As Dr. Schreiber mentioned, one of the biggest challenges is that we're starting to see behavioral and mental health earlier and earlier. the younger group, the 5 to 9-year-old, even though the actual numbers, as Dr. Schreiber mentioned, the actual numbers are not very high, but you can see here that suicide is creeping into the top 10 cause of death for these younger age groups. And the challenge here is we really don't have a lot of information about how would one manage a 5-year-old or a 6-year-old who comes in with suicidal ideation. So that is particularly challenging for our healthcare system, trying to appropriately develop resources and efforts to managing those patients coming in with suicidality at such a young age. Next slide. Again, if you don't mind, just keep pressing until everything populates here. So again, as mentioned, the problem is that there is a great risk of suicidality, but not every single child who comes in and makes a suicidal comment is having a high likelihood of suicide. So there are actually those who are specifically at higher risk, and there's some evidence to support there's a way that we can try to identify those who might be actually at higher risk, screen them, and be able to prioritize them over the others who may not necessarily be a high priority. And we also, on the slide you see with the pie chart here, two of the most common, the ones that basically account for everything, causes of suicide are firearms and suffocation. So lethal means restriction becomes a very, very important intervention than one can have. Simply access to firearms, access to ammunition that goes into the firearm, and things like that should be part of what every household has in their plan to avoid any accidental problem that maybe a 6-year-old or a 7-year-old can get themselves into, or adolescents who may use that means to commit suicide. As we know, firearms cause extremely successful suicide. So that is an important thing to consider. Next slide. So this just basically a diagrammatic representation of why we have such a big problem. The slide to the left basically shows you where all of the mental health professionals live. So if you look, the East Coast and the West Coast is better supplied with psychiatric specialties. The middle of the country, not so much. And it was interesting, I was reading somewhere that up to 55% of all the counties in the United States do not have a single mental health professional that is staffed. So that means all of the children in that area are going to have zero access to a mental health professional. And that, again, is why we in the ED are such an important part of this solution. I think one more slide press, because there's one more. Yeah. The two maps that you can see on the right, the one on top shows you where all of the population of adolescent patients who need psychiatric services. And as you can see, it looks like the middle of the country is a lot more in need than the coastal regions where the psychiatrists are. So there's the disproportion of where the need is and where the supply is. The lower right is the one that shows you where those areas are, where at least 50% of children who need psychiatric support or psychiatric evaluation don't have one or don't get one. And again, you see that this parity there. The one in the middle, the darker it is, the more of a lack of coverage by mental health you'll see. So as you can see, the entire country pretty much is a shortage area, severe shortage area of mental health professionals. Next slide. So the ED, and the reason why we are all here, is a very important area to address this. I would say, as a practicing emergency physician, I'm seeing a lot different kind of scope of my work as what I expected when I was training. I really wasn't expecting to be running into so many of mental and behavioral health issues as I am now. So it is fair to say that I wasn't prepped and prepared and educated as well personally on how to manage this. So it's a lot of learning curve here for me to figure it out. But why is the ER such an important point? The answer is really, the prevalence of mental and behavioral health is obviously increasing. The recognition of children and adolescents with mental and behavioral health is increasing. The referrals from families, from schools, from primary care offices, from clinics increases. And there's also a continuing decline in the number of outpatient psychiatric services, hospitals that take care of psychiatric patients, mental health professionals who see you in a primary visit. So basically, all of these are going to get referred to the safety net of the healthcare system, which is essentially the emergency department. So we have a lot of people coming with very few places to go. And that is why the ED is such a hub, gathering all of the mental and behavioral health complaints. Next. So that means, as Dr. Duffy mentioned, we have a place to do something about it. As a matter of fact, there is something we have to do about it. There's no other way around it. It would have been ideal, and some places have this. There's some proof of concept of crisis intervention centers that, for example, a pre-hospital team can bring the patient directly to that crisis intervention center and avoid a transport to the ER. Those are rare. It's very hard to avoid the ER. Most people are familiar with bringing the patient to the ER. So that's kind of where patients mostly end up. So while in the ER, there's a couple of things. First of all, we should be able to screen patients, should be able to identify those that are at higher risk, and then potentially be able to do some additional screening for those that we flagged as higher risk, just to determine how severe the problem is. Then be able to perhaps either provide some ED-based intervention or have a good access to a mental health professional when possible. Be able to practice some of this counseling, such as lethal means restriction and things like that. Also, just like we have with agitated patient, for example, being able to understand that there are ways that you can speak to somebody and talk them down from either agitation or suicidality, and being able, for example, to use the least restrictive means rather than giving somebody physical restraints because you're afraid they're going to harm themselves. And then there are other interventions. I mentioned this social ecological cognitive behavioral model, the Safety A. I put a reference there. This is a really amazing program developed by Dr. Joan Asarno from UCLA, and she has a PCORI going on this. And if any teams choose to use ED-based intervention, this would be a great resource to kind of go with. And then also the concept of regionalization of mental behavioral health, which means you basically know you have a limited supply of mental and behavioral health professionals, and to have contracts with them so they can cover multiple hospitals. The other concepts that everybody talks about, which is expand space and expand workforce, those are more like pipe dream for a lot of us. We can't just create extra space and we can't just hire extra people, but technically those things are part of a solution. And they will probably start with advocating for more funding and more resources and more support. Next. So this just briefly, and Dr. Remick will talk a little bit more about this, but this is kind of part of what I'm involved with the EMS for Children Innovation and Improvement Center. The goal of it is really to improve the care of children through a series of quality improvement science, multidisciplinary system collaboration. So the goal really is a child, no matter what hospital in this country they show up to, they should have access to the same high quality evidence, science, and perhaps resources to the best of their ability, so that that does not be a deciding factor for how the child is going to do just because they happen to show up at a tertiary care children's hospital versus a general ED in rural Wyoming, for example. And the EMSC family of companies includes the EMS for Children Innovation and Improvement Center. And this ED Stop Suicide Collaborative is really a project sponsored by the EIIC. The other members of the family, as you guys may know, includes the PCARN, which is all you guys know about, the data center in Utah, the state partnerships, and the target issues grantees. Next. So my final part of my talk is the work we have been doing at the EIIC. We have put a great emphasis on mental behavioral health. We specifically put a lot of effort and resource into content for suicide. So we call these PEAK, the Pediatric Education and Advocacy Kits. So we actually have a PEAK suicide, and there's a QR code for the resource for you guys to go directly to. We offer there, you can go to the next slide. Yeah, again, the same, I left a QR code up here for you just in case. So that's what the page looks like. It actually sorts it out by what content is meant for clinicians, what's for nurses, what is patient and family resources. We do have the full 104-page document, the critical Crossroads toolkit, as both, I think Dr. Duffy and Dr. Schreiber mentioned. And we also created a series of algorithms and bottom line recommendations in conjunction with our partners in Canada called TREC. This is a multi kind of modality set of resources. We have webinars in there, we have learning module, we have infographics and podcasts that you can look through. One of the podcasts specifically is with Dr. Jonah Sarno, the safety A person, and she talks specifically about if a patient is screened positive for suicide in the ER, what should we be doing? And then there's one interview with Dr. Lisa Horowitz, who is actually the co-developer of one of the most used validated suicide screening tools, the ASQ. So we have a lot of resources there for you. More will be added. So this will be really serving as a encyclopedia of information and resources for you guys to tap into. Next slide. And this is my final slide as I transition into Dr. Ramek's talk. So the collaboratives, I think they're just a fantastic opportunity for like-minded, passionate people who really want to improve the quality of care that is delivered in their hospital. So it's really meant around a specific target, in this case, suicide, and having people, groups of people from different organizations work together in a cooperative and a collaborative way to learn from each other, to share information with each other, and help contribute to outcome improvements and change in practice to best practices in their facilities and in their region. So we're very excited to have you guys be part of this, and we have several, over 60 teams, I think so far I heard, that we have participating in this collaborative. So it's really a good opportunity for you guys to learn from each other, work with each other, and help make a huge difference in the way that we approach, we screen and we treat patients, children and adolescents who come in for suicide-related complaint. I'm going to pass this now to Dr. Ramek to take us home.
Thank you so much, and thanks to you and Dr. Schreiber and Duffy for sharing such critical background on why we're here and why this is such an important issue to work on. I currently serve as co-director for the EMSC Innovation Improvement Center, and I'm based in Austin, Texas at Del Med School. Thank you all for joining today. If you could go to the next slide, please. What I wanted to describe over the next few minutes is why you might choose to join the ED Stop Suicide Quality Improvement Collaborative, and really describe a little more of the specifics about the collaborative and what that will look like over the next 9 to 10 months or so. If you could go to the next slide, please. As you heard from Dr. Sadinejad, we are part of the federally funded EMS for Children program. We are funded 100% through HRSA, and we are grateful for their support. And our goal with this entire family of EMSC investments is really to reduce childhood death and disability due to severe illness or injury, and certainly mental health stands as one of the key priority areas. And our goal is really to enhance our emergency care systems to make sure that they're better able to support the needs of those children. And our work, while it focuses across the entire continuum, in this particular collaborative, our work is predominantly focused on the emergency department setting, because that's where much of the evidence base currently is, as you've heard from Dr. Duffy and Dr. Schreiber and Dr. Sadinejad. Next slide, please. Because our work is to improve emergency care systems, I want to be very clear that this Quality Improvement Collaborative is not specifically for children's hospitals or high resource centers. In fact, much of the work that we do focuses on the entire emergency care landscape and the emergency care space. The foundation for many of our programs is based on pediatric readiness. There are a couple different joint policy statement and guidelines, one of which is here on the right-hand side of your screen, called Pediatric Readiness in the Emergency Department. And this work is really intended to bring up every emergency department. And the reason this is so important is because over 80% of children are seen in general EDs. And most of those EDs see fewer than 15 children per day. And so it makes it very challenging to figure out how we can elevate our clinical care processes to meet their needs specifically. Next slide, please. The EMSC Innovation and Improvement Center was formed initially in 2016, and it was formed with the intent to use quality improvement science as a foundation for implementing evidence-based into practice. We have a very strong arm in knowledge management and knowledge transformation, and you just heard Dr. Sadinajad talk about our pediatric education advocacy kits that provide a lot of that translation into practice in the development of resources. We also leverage partnerships, not just with professional organizations and families, but really across the country with all of you. And we view our frontline healthcare providers as a key stakeholder in the work that we do, with the goal of increasing access to these high quality services that meet the needs of children. Next slide, please. So as a foundation for our quality improvement work, many of you are likely familiar with the Institute for Healthcare Improvement's model for improvement. And each of you could certainly undertake this work utilizing the resources that exist on our website and implement these efforts on your own. But what I hope you'll understand is the benefit potentially of joining a quality improvement collaborative, because we really take that model for improvement into action. And as you heard from Dr. Sadinajad, much of our focus is on shared learning. Over the last many months, we have recruited national subject matter experts and faculty who have worked hard and diligently to develop the framework to support this quality improvement collaborative. And we're really excited to be launching this collaborative next month. Next slide, please. Part of the benefit of these quality improvement kits, as well as from the Critical Crossroads document. We utilize QI methodology to help support ongoing improvement efforts. We have centralized project management support and IT infrastructure, as well as data management. And so much of the benefit of these quality improvement collaboratives is really seeing what's happening across the nation at similar institutions, diverse institutions, and really being able to learn from each other, adopt those best practices, and hopefully refine them to better meet the needs of the resources at your institution. Next slide, please. So the global aim of the ED Stop Suicide Collaborative is to enhance ED-based clinical care processes for children who present with suicidal ideation. As a participant, you will have access to coaching by experts in pediatric mental health and suicide, coaching by quality improvement experts, opportunities to develop partnerships on a regional and national level, access to best evidence and resources, of course, shared learning. As part of all of our collaboratives, it's important that as a team or as a site, we understand a little bit about who each of you are in terms of your background, so we can guide that content accordingly, which is our intake form. And then secondarily, our environmental scan, which is a way for us to understand the current landscape and where the most common opportunities are for improvement. As a physician participating in this, you'll have the opportunity to receive MOC Part 4 credit. For those of you who are on the nursing or social work side, we are in the final stages of getting our continuing education credit out for all of you at no cost. Next step, slide, please. So these are the key steps in the clinical care process, and many of you are aware when a patient presents to the emergency department, there's initial triage and then ongoing assessment, interventions, and disposition. And we've taken that and developed it into tangible, more digestible, bite-sized chunks that any participating ED can participate in. So the first being, how do we optimize suicide screening? Next, how do we optimize the mental health assessment? How do we look at our ED-based interventions and figure out how we can better create standardization, family-based areas of focus and interventions? And then last, moving into the discharge and safety planning process. Patient and family considerations are really woven throughout all of this work. And ultimately, we are excited to be able to bring in additional partners, pediatric mental health care access grantees, that will help us to identify ways that we can leverage regional resources. And also by introducing you all to our EMSC state partnership program managers that are in every single state and U.S. territory, who are excited to be able to support pediatric readiness efforts such as this one. Next slide, please. We hope that every team will identify at least 2 individuals, and that's because this is really team-based work. It's hard to do this work alone. We know that it is also a multidisciplinary environment. So for those of you who are looking to figure out who might be on your team, bringing in social workers or even security sitters, child life specialists and the like is certainly encouraged. Some of our teams even identified family representatives, so we ensure that we are really integrating the needs of families and patients. We estimate that this work to implement a quality improvement effort to improve your clinical care process will take approximately 2 to 6 hours per month. It's really how many hours you and your team has available and wants to put in. We know everyone is currently strained right now by the pediatric surge. We know about workforce shortages, but it's really what you put in is what you get out, and there's no minimum expectation necessarily. We just hope that we can support all of you to implement a quality improvement project. The other thing that I want to emphasize about this is that we are not overly prescriptive. So it's you choose what you want to work on. And these are the key areas of focus, as you saw on the, you can go ahead and go to the next slide. On this slide on screening or triage, assessment, ED interventions, family-based interventions, and or disposition. And it's really in those last few months that we're going to really dive into how we can leverage regional resources, especially given the fact that, as you heard from Dr. Sadinajad, over 50% of counties lack mental health professionals. So next slide, please. When we move into leveraging regional resources, we really want to help to support you to identify what those might be. So it may be through partnering with other participants that are in your region, connecting with your EMSC state partnership managers, as I mentioned, leveraging these pediatric mental health care access grantee programs, and then hopefully even beginning to figure out ways to collaborate with either schools or pediatricians in your region on how you can optimize the discharge or disposition process. Next slide, please. So our SMART aim is that really for all participating teams that each of you and your team will have identified and implemented at least one strategy to improve clinical care processes for children with suicidal ideation. We will walk you through this process. You do not have to have any quality improvement training to participate in this QI collaborative. Those of you that do, fabulous. You'll be one step ahead and be able to, hit the ground running. But those of you who don't, please don't be intimidated. Our goal is really to walk you through this process. We'll go through initial orientation and introduction to how to implement these QI efforts in February and March. We're so grateful for a number of national subject matter experts who will be hosting and leading what we call fireside chats, which is really a live Q&A session where you'll get to ask lots of questions about how do I implement this in my ED given my resources. In April, we'll really start trying to mobilize. We hope you'll by then be ready to declare an area of focus, develop your own aims, and begin making improvement processes. Through May and August, this is when we hope you'll begin to accelerate those improvement efforts. And in September through November, we'll be diving into sustainability and really formalizing those partnerships along the way. Next slide, please. Posted on our website is a calendar of events. If you've already registered, make sure you know what these dates are. If you haven't yet registered, go to the site so that you can look at these particular dates and go ahead and hold those on your calendar. All of you who have registered should have gotten meeting invitations to our core learning sessions. The fireside chats are optional, and they're really based on the specific area of focus that you chose. During our learning sessions, that's when sites will be able to share their work and their progress, learn from each other. We'll be dividing folks up into smaller groups so that there's a real opportunity for discussion. And we look forward to seeing what improvements are made over time. Next step, or slide, please. In support of this collaborative, there are a number of resources that we'll be sharing with you that include intervention bundle guides and suggestions for strategies. You've seen some of the other resources, the peak suicide, the critical crossroads, the environmental scan that'll help you to identify what you want to focus on. And then, of course, these other areas that I've described. So all of those will be coming to you as a participant in this collaborative. And next slide, please. So during the learning sessions, the first few during the orientation and mobilization phases, it's really on us to be able to share with you kind of how to do this work and really get you started. But as we transition into April and beyond, we hope that each of the teams will come prepared to share some of the work that you're doing. And we will provide a very abbreviated slide template to guide you. Just introduce your team, talk about the work that you're doing, talk about what you plan to work on. There'll be small group breakout sessions, and in those, you'll have access to a quality improvement coach as well as a subject matter expert. And this is where the learning really happens, because you really get to learn from each other. Next slide, please. So I'm going to turn it back to Laura Aird to close us out. Thanks so much.
Thanks, Dr. Remick, and I'd like to thank all of the speakers for their time today and their expertise. It's been incredibly informative. So registration for this QI Collaborative has been open since October of 2022. You might be interested to know that we've got 66 teams that include 197 participants, and of those team leaders, 16 of those folks are EMSC state partnership team folks. There are 27 states represented in all federal regions. We would still like to encourage as broad of a group as possible. So if you haven't registered a team yet, you're welcome to do so. I put my email, my name's Laura Aird. I'm a senior project manager for the EIIC. My email address is in the chat, but there's a typo. So laura.aird@austin.utexas.edu. And thank you, Stacy, for putting a question in the chat box. We were beginning to wonder whether it was working, and Dr. Saeed-Dinajad is in the process of answering that question. I also wanted to mention that there is a web page link on this slide. There are 2 pages that describe the collaborative in detail, just as we've done so today. And you are welcome to identify an ED-based team leader to complete the registration online. It's pretty quick, less than 5 minutes. You can add the names of up to 2 team members from your site online. If you need to add more, you just email me and we put them in our chart. Those of you who are already members of this collaborative have received several emails from us, and we will continue to communicate with you until the collaborative starts. Please complete your registration soon. We're pleased to be able to extend the registration. It was going to close tomorrow, but we are extending it to January 20th, which is at least a week away. So please register. And then I'm looking to see if there are, I do not see any other questions in the chat, but I want to give the panelists a second to reflect back on everything that's been discussed to see if they'd like to bring up any final points. We are almost at the hour.
So I answered that question in the Q&A. I probably answered it incompletely because I didn't get the last part of it. So if Stacy, you wanna in the next few seconds, if you wanna just clarify what you mean with being successful in getting school initiated. That part I didn't understand.
While Stacy is perhaps typing, a guest mentioned that they've registered but have not received any follow-up email. That's likely because you might have registered right before the holidays. We have a group of messages that still has yet to go out. So don't worry about that, and I will check on your name. Again, anybody with any questions afterwards can email me. These slides will be posted online, and you will all receive an email with a recording of this webinar and the slides. And you're welcome to encourage your colleagues to join as well. And there are resources, and we'd like to thank you all for your time. Have a good day, and thank you so much.
Thank you all.
You are welcome, Heidi. Panelists are welcome to stay on for a debriefing if they wish.